Thank you very much. Good evening, colleagues. It's wonderful to see so many people from so many different countries. Thank you for indicating where you are from and for joining us. So here in South Africa, it's evening, and I think for most of you, or some of you, it's in the morning, and I think for some, it's in the afternoon. So you are welcome. We are really looking forward to this session. We've got three wonderful experts that's going to take us through all the different topics on delirium and all the latest guidelines and interesting things. And we're really looking forward to your talks. I'm not sure if I'm seeing Joseph yet,
He,
Kathleen.
he will be coming.
Oh, okay, so he will
Uh,
be coming.
right. And both Isabella and I will be monitoring the chat box and the Q&A. If you have questions or you want to comment to something the speaker had said, feel free and we'll keep an eye on things.
Okay, excellent. No, thank you. So during the presentation, as I said, we will have three presentations on different aspects of delirium. And as Kathleen have indicated, you are welcome to please just write any specific question in the chat box. So in between the three presentations, there will be some time for questioning, or you can then just make a specific comment, and we will then give you opportunity. Also, at the end of the presentation, we will then there will also then be opportunity for you to evaluate the session, and also after the evaluation, then if you've completed the evaluation, you will then be able to download a certificate of attendance also at the end. So we will also just remind you during the end of the presentation then to please evaluate our session. And we also then usually ask for any other topics. So you are also welcome to indicate if there's any other specific topic. So we always try every 6 weeks, when we have 4 to 6 weeks, when we have our webinars, to also address some of those aspects that our colleagues have indicated which they would like to have a webinar on. And we'll also soon be also advertising the upcoming webinars. So I think then we've got the presentation of Joseph up. So he's going to present first on the tools
Oh,
on the.
actually, sorry, that's my fault.
Oh, I wanted to say, I thought you were going to be first.
No, I think
So,
Renan is.
Renan is first. And then,
I made a mistake and put the slide in too early.
oh, no, no, that's
Oh,
100%. I just thought maybe I'm
no,
confused here.
no, it's
So
it,
our three guests, they have
no,
sorted themselves who's
that's
going
my
to be
boo-boo.
first.
There we go.
And then also, I just want to say a special welcome to all of you, and then also a special welcome to Kathleen, who's our president of the World Federation of Critical Care. It's always nice having her, and also we are privileged to have her as one of the presenters tonight. But first in line, it's going to be Renan Ribeiro. So Renan, thank you so much for your time and for your willingness to present to us today. I almost said tonight because it's night this side, but we really are very glad that Renan could also join us. So he's going to talk on delirium assessment in the neurocritical ill patient. And I think that's going to be a very interesting topic. So he's specifically going to focus on the fluctuating mental status and also on the evaluation. So as you can see there from his all his qualifications, he's really very experienced. And he's also the secretary of the World Federation of Neuroscience Nurses.
He's the
And
president
he's
now.
also, sorry?
He's the president now.
Oh, wonderful. So much more. But yes, also well experienced, and he's also the past president of the Brazilian Association of Critical Care Nurses, and as Kathleen just indicated, currently the president. So, Renan, thank you so much. We're looking forward to your presentation. I'm going to hand over to Renan, and just reminding our colleagues to If there's any specific questions between me and Kathleen, we will then make sure to keep an eye on the chat box. And as Kathleen said, those of you who want to change a specific language, you're welcome. And we hand over to you, Renan. Most of the presentations can be plus or minus 20 minutes. And then after that, we'll have some time for questions and answer before we go to the next presenter. So Renan, over to you. Thank you so much, and we look forward to your presentation. Thank you so much, and enjoy, colleagues.
Thank you. Hello, everyone. Thank you for having.
Renan, you have muted yourself.
Can you
There
hear
you
me
are.
now?
Yes, now you are audible. Thank you.
Okay, thank you. Can we hear me now? Okay, my sound? Yeah, can you hear me? Sorry, can you hear me now? Okay, good. Yes. So thank you so much for having me today. I'm Renan from Brazil, and I will talk a little bit about the delirium assessment and neurocritical ill patients. This initiative to discuss this today is in consequence a discussion that we got about how important to celebrate and to be aware about delirium in hospitals in neurocritical care and critical care, and how nurses play an important role to change this. So this in the last month we got a special celebration for to be aware about that, and we started a discussion with basic topics to put everyone on the same page. First, it's important to understand how important to talk about delirium, and this research show us, and they followed patients in ICU with delirium assessment and after discharge, and when they assessed the patient 3 and 12 months after the ICU internation, they could observe that the patients that got delirium got more disabilities and worse cognitive function. So apart this point will be clear for us how impact of delirium on the patient quality of life and the patient recover and how this patient back for society. So once that we know about delirium, it's important to understand the definitions. I will not be deep concepts here because we got more conversations with Joseph and Kathleen, but it's important to understand that delirium is different than another conditions that people usually talk about: acute encephalopathy, acute confusional state, or acute brain dysfunction. So all these conditions are different. Delirium is a one kind of demonstration of the major problem with the neural system. And there are a lot of features are specific for to say the patient have delirium, like for example, the onset of the symptoms that start in the few minutes, hours, or days is very acute. This patient should demonstrate inattention and can be followed by another features like mental alterations, emotional alterations. So there are tools to help us to recognize how these happen in these patients. However, it's to know nowadays we know that is very common situation all patients in ICU. However, we have got a special kind of the patients that are responsible for the most of internet admissions in ICU, like patients with neuro conditions. So it's big challenge to understand what has happened part of the brain acute injury physiopathology as well as delirium. So because the patient can have acute ischemic stroke or intracerebral hemorrhage, a lot of trauma brain injury. However, we have a different mechanisms of lesion, alterations in perfusion, alterations in brain tissue, and these can put the patients in more risk to develop delirium, because we know that also these patients are exposed are the same features of critical patients ICU, like sedatives, like immobilization as well. A lot of research demonstrate for us about the incidence and prevalence in delirium in neurocritical care patients, and the numbers demonstrate our variability because we have a lot of methodologies, different tools that are used to recognize delirium. However, it's clear that neuro patients have delirium too. It depends of the situation. So, this is important for us to understand how this happens, especially what this impacted these patients. Uh, Another important point is a good systematic review with past years in 2018. It was a few studies with a few number of the patients, but in this research, in this review, it was clear that the patients can develop delirium, and the both tools that are more common to use to assess delirium, the CAN-ICU and intensive care delirium screening checklist, are both apply to assess delirium. However, intensive care delirium screening checklist maybe could be more specifically for these patients with the best performance if compared with the CAN ICU. Next, please. As well, in this review, we can get about the negative impact of delirium, especially in neurocritical care patients. And it was not clear specifically about mortality in this specific population. However, we need to consider the limitations of this review, especially in the number of the patients and the number of the studies that was used to demonstrate the impact of delirium. Now we have more recently studies. It was about a specific tool that was valid in patients in neurocritical care unit. It was established for the nurses from Denmark, and they apply the CAN-ICU and intensive care delirium screening checklist to assess delirium in the patients in ICU and compare with ICD-10 to classification of disease. And the results of this study show us is very feasible to assess the delirium in patients in neuro ICU. We can see that the both part of the patients were able to be assessed. The prevalence of delirium, it was high in the patients with neuro conditions, and the performance of intensive care delirium screening checklist, it was a little bit better if compared with a CAN ICU. Another study most recently that was focused in research in the patients with cerebrovascular disease in ICU, conducted in the United States with Michelle Ballas, Thomas Lansell. They assessed this 169 patients in ICU. They used the CAN ICU to understand the presence of delirium and the CAN ICU 7 to understand the severity of that. And the results, it was very similar that we already know about delirium neuro patients, because the prevalence it was in the 44% in these patients. All these patients demonstrate a high severity of delirium with CAN ICU 7, and it was associated with the worst outcomes, like more days of ventilation, more long stay in ICU, and discharge, impairing discharge, and more severity, disability in these patients. Now we know this is clear for us that these patients also have delirium. And nowadays, what is the recommendations that we use to assess delirium in these patients? And the PEDS guideline that start in your first update in 2013, after in 2018, and more recently in the last years, they first moment recommendation clear for CAN ICU and intensive care delirium screening checklist. And the last one, they recommended to apply a validated tool, because nowadays we have a different tools that we can apply in different situations. But the most common when they scales with more good performance to assess delirium in general population, it is the CAN ICU and intensive care screening checklist. As well, we have recommendations specifically for assess the patients with neuro conditions. It's a little late in 2014 in the Neurocritical Care Society recommendations to assess clinical scales in patients in the ICU with neuro conditions. They recommended to use intensive care delirium screening checklist to assess all these patients too. It's important to know that we have a lot of tools to assess delirium, like CAN ICU, 4AT, intensive care delirium screening checklist. However, all these scales are not created and they've developed specifically for patients with neuro conditions, because when you have specific neuro conditions, you have specific issues and the brain damage in different parts of the brain, and the patients can develop a lot of symptoms that can be very hard to us apply these tools and understand and to say if the patient have or no delirium, because the patient can have aphasia, the patient can lose the visual or hear function, and a lot of the limitations in neuro conditions are not contemplated with these scales. However, nowadays they try to understand what tool can help us to assess delirium in this specific population, and it was developed more recently. It was the functioning mental status evaluation. Is a new tool that was developed to assess delirium specifically in neurocritical care patients. Please, the next slide. And this main idea to use this scale because they have a definition and functionally specifically for patients with neuro conditions. For example, they establish a new baseline patient after the acute brain injury. That's the good point, is the main message that when try to understand delirium in neuro patients is to determine the new patient mental status. As well, these features in this scale explore non-verbal features because aphasia or not limitations to communication. And another important point, this tool is adaptable are the patient condition, because we know that at different neurological conditions, the patient can develop different levels of the consciousness. So in the interaction with the examiner is a little hard sometimes to do. And here we have different stimulations for the different levels of consciousness. This is very useful to understand what is happening with these patients. The fMSE scale have 5 domains, 5 features like consciousness, attention, activity, orientation, and thought content, and is recommended for nurses assess for all these features associated with the patient history as well the data of clinical examination of this patient. And the research that validated this tool demonstrate here the most common domains and the features that are altered in these patients, like consciousness followed by attention, activity, and orientation, and the thought content. So the validation of the study you performed for the clinicians for UPMC in the Pittsburgh, they assessed almost 150 patients in ICU with acute conditions like ischemic stroke, intracerebral hemorrhage, and the subarachnoid hemorrhage, and a total of 717 assessments are paired with this scale when the criteria for mental health classification for delirium. And they apply the same tools by physicians and the APs from the unit, and they got a good results when you compare the results of the scale and the delirium development. For example, we have 5 domains. For each domain is present, we'll put 1 point. And if the patient have 1 point, this is a possible delirium with a good properties. Psychometric is demonstrated as a good too. As well, if the patient have the score higher or same to this a patient with probably delirium, and as well is a good indicator for true screening. Is a good point of this, it was that the patients with aphasia, that is very challenging for nurses to assess delirium with CAN ICU or intensive care delirium screening checklist. It was able to perform assessment of delirium in these patients as well with good performance in terms of sensitivity or specificity. Here we can show the results of the graph, the area of under curve that shows this a good tool that we can believe in this tool. However, we know there is limitations as well. because a lot of limitations with different scales, we try to discover the best one, the best scale, yes. But the first limitation of this scale is was the difficult to continuous detection, even though it's easy to apply the FMCI. Sometimes it's not easy to follow these patients because to demonstrate the oscillation and variability and the consciousness is not good. Maybe for the screening, the initial screen and triage this patient, maybe it seems the good option about this scale. Another limitation is this scale was developed for neurocritical care patients with limitation in communication. However, in this study, they used it specifically in patients with cerebrovascular disease like ischemic stroke, intracerebral hemorrhage, and the subarachnoid hemorrhage. However, if you think in the patients with brain tumors or patients with TBI, we need to consider to apply these patients to understand how will be the performer this scale, especially in terms of sensibility and specificity for delirium. Uh, Another patients with more complicated were excluded of this study. We know that the patient previous stata is an important risk factor for delirium develop. And in this study specifically, they didn't compare the FMSI with CAN-ICU or intensive care delivery screening checklist. However, we need more studies to understand how this scale will perform when compared with the basic and the more diffuse scales. However, these are important points is that this scale are specifically for patients, especially to remember to nurses to define how is the new neurological status of the patient to define what is changing, what has happened. Because one feature important of delirium is the oscillation, is acute condition that the patient now is present, now is as absent. So this is limitations of this scale. Please, the next slide. For before we start to assess the patients with the 5 domains of the FMCE, it's important to first determine the patient more recently baseline. So nurses need to ask what they were like prior to hospitalization, what they have been like after their stroke or brain injury, because this question is important to understand what has happened with these patients. Another question that nurses can do is what is the patient like before the hospitalization, what is the previous baseline of these patients. All these conditions is important to nurse ask. Next slide, please. Another question is what's the patient been like over the past few days? What is patient been like today? Anyway, a lot of questions that nurses to ask what is different before hospitalization or before in the day before today. So is sometimes you need to get records to understand what has happened, the communications in the nurse when it changed the shift. A lot of this information is important to decide what is happening with these patients. The next slide, please. The step 2 is important to determine if there have any changes in the patient more recently established baseline. So the nurses need to review just change, understand what is happening, describe what is happening with these patients. It's important to know that sometimes the family or the another professionals can be a source of information, what is happening to the patient, what is the normal the patient behavior, especially to get conversations like a neurosurgery for understand the new behavior, the new mental status that we expected of these patients with after brain surgery, after hemorrhage as well. The next slide, please. And in the end, the last step before to start to evaluate at each domain of the scale, the nurses need to assess each one about it to understand what is happening in these patients. Okay, the next one, please. So to understand a little bit about the FMSE scale, the first you need to determine the baseline of the patient. After all, we check the 5 domains of a scale. After that, we look for the wave, is the transition of the patient, and now in the end, we'll got conclusions about this condition is present or no in your patient. This is the scale. Here we can see the 5 domains. I will not explain each one because it's very easy. The scale is very easy to understand. We have recommendations for how to apply each point, each one. The first one is about the fluctuation of the consciousness that nurses will need to assess. Usually, if the patient has changed or not the consciousness of this patient, what has happened with one. Please, the next slide. And the nurses need to understand if you need to any kind of stimulation of this patient, because every time that we need more intensive stimulation of this patient, we can realize that how this patient can keep the attention of the nurses in the next feature. Please, the next slide. So this is the specific instructions to interpret the results of this scale. This is available in the paper that was published in Critical Care Meds, as well the supplement that have the instructions to apply the scale. The next slide, please. The second one is about fluctuation orientation. Here, in the same time that we are asking the patient about where is the patient, how the name of the place. The next slide, please. Like usually to assess the patient in the Glasgow Coma Scale, example, is a good way to assess these patients as well. Next, we have questions about the person, the time, the place, the situation, and as well. The next slide, please. And the third feature, Marwan, is about fluctuating activity of these patients. And in this moment, the nurses need to get attention for 3 moments of the patient. And the patient without being stimulated, with stimulated, and the patients in another time is like in the patients in the bath, and the patients during the sleep, or I get conversation with the family. What is the behavior of the patient when we don't have interaction with health providers? This is a good strategy to understand about the behavior of these patients. As well, we have specific recommendations how to apply and how we can consider these behaviors that the patient get more activity or less activity. However, this scale don't demonstrate if the patient have a hypoactive delirium, hyperactive delirium. In this moment we can get this information about this in terms of movement and activity. This is another feature in delirium. The next one, please, one more. And the fourth feature of this scale is the fluctuating and the thoughts of the patients. In this moment, the nurses will determine if the patient is conscious, if the patient is able to perceive stimuli and aware about the environment. As well, the nurse will determine the patient contents, and in the end, the nurse will reflect if this contents make sense. This patient have a coherent thoughts. Next, please. So the feature will be present if the patient demonstrate incoherent sound, disorganized, or describe visual, auditory, or hallucinations as well. The next slide, please. And the last feature of this scale, one more, is a fluctuation of attention. This is a good point of this scale because here we can adjust the level of stimulation of the patients in depends with the level of the patients. For example, in the most level of the patient, we can use the backward digit span. If the patient have a lot of alteration of the conscience, we can use the forward digit span. Or if the patient is less of the consciousness, we can try to a less intensive stimulation, like only verbal commands, as well if the patient mimicking commands. And for the patient that have a important decreased level of the consciousness, we can try to only assess the patient's visual attention. If the patient can keep the eyes on the nurse, if the patient try to understand what nurses are doing or nurses are talking for him. So this is a good point of this scale in terms of to adjust the assessment for the level of the consciousness of the patient, because sometimes nurses, when I try to apply can ICU or an intensive cardiac screening checklist, they need to say this patient is unable to assess now because they don't have level of consciousness. So if you adjust the level of the consciousness for the patients according of the brain injury, we can even with some limitations, understand if the patient have attention or not in the examiner. Please, next slide, please. Next one more. Good. So in the end, it's important to understand that when the patient demonstrates the positive features for the FMSE, we can think in the neurologic conditions or systematic conditions to classify if this can be or not be delirium. Because if you can explain the change of the consonants by delayed cerebral ischemia or another condition, you're not delirium. But however, even though the patient have subarachnoid hemorrhagia, they don't have alteration in the Doppler transcranial. The patient don't have signs of delayed cerebral ischemia, but have alteration level of the consciousness and the content of the consciousness with the scale is positive. We understand that these can be delirium. Yes. The next one, please. In the end, we understand that delirium, the FMSE scale have two main scores. If the patient have 1 point or equal 1, this patient is a possible delirium. If the score is the 2 or more, this patient is probably delirium. Next one, please. So in this one, we understand that delirium are prevalent in the patients in ICU, especially in neurocritical care patients, that we can get almost 60%. It's important to use a standard screening tools for assessment delirium. It's important to understand that when nurses don't recognize delirium, it is associated with outcome of these patients. Even though this is a specific scale for neuro patients, they demonstrate a good accuracy and predictive value. We know that have some limitations. We need more studies and research, especially in patients with another conditions like TBI, brain tumors. It disseminate this scale, it disseminate this knowledge about delirium neurocritical care patients is very important to do research and the big research, multi-center studies to help us really understand what is happening to patients. However, it's important to understand that neuro patients can get delirium too. It's very hard for us to understand that. The nurses need to understand and to know how to identify this situation. This is that I have to explain for you today. Thank you for your attention.
And Renan, have you, this is Kathleen, have you implemented this scale in your clinical area?
Not yet, but in Brazil, we start a validation in Portuguese of this scale to start to use in this population.
Awesome. I'm going to stop sharing just for a second. Thank you so much, Renan. We're going to switch speakers. Isabel, if you'd like to introduce Joseph. I also want to let everyone know Joseph is going to be, and Joseph, if I get this wrong, let me know. Joseph is going to be presenting in Spanish. And so if you could put your caption, if you speak English, in as English so that you get the captions on your screen. So go,
I'll say thank you very much, Kathleen, and thank you to Renan for a very interesting and comprehensive presentation. I don't see any questions at the moment, but at the end we will also have opportunity for colleagues to ask questions. So in the meantime, if you do have any questions, please just put them in the box. Then our next speaker is Joseph. Joseph is also with me, part of the education committee of the World Federation of Critical Care. So we work together, and we are also he's also a part of the team planning all the webinars, and we're also very privileged to have him as a speaker tonight. He's also a very skilled and knowledgeable and well-experienced critical care nurse practitioner, and he's also, as I said, one of the education directors of the Critical Care World Federation Society. So we are very honored to have Joseph with us tonight, and he's going to take us through all the different tools to for the identification of delirium. in the ICU. So we can see also that the talks do complement each other. And thank you very much for your willingness, Joseph, to present. And we are looking forward to your presentation. And again, I'm just reminding the colleagues, if there's any questions specifically, please write them in the note box, and we can then attend to those questions afterwards. So please enjoy the presentation. Thank you so much, Joseph, and enjoy. Thank you.
Thank you so much, Isa. Thank you, Kathleen, Renan. Welcome, everyone. Greetings from Mexico. I'm Joseph Nurse, specializing in neurology and intensive care. This presentation will be in Spanish, so please turn in English subtitles, please. Bueno, primero que nada, muchas gracias a todos los que están aquí con nosotros, que también hablan español. Agradezco bastante la oportunidad que se me otorga por parte de la Federación Mundial de Enfermería Crítica, el otorgar esta presentación enfocada a lo que son los pacientes con delirium. Como tal, como lo comentaba el maestro Renan Martins, el delirium es la forma más frecuente de disfunción cerebral aguda en nuestras unidades de cuidados intensivos y se va a asociar con mayor mortalidad, una estancia mayor prolongada, un deterioro cognitivo a largo plazo y desafortunadamente a una carga para la familia. Next slide, please. Yes. Eh, Algo importante que tenemos que conocer es cómo se clasifica el delirium. Tenemos tres aspectos muy importantes de cómo se va a clasificar el delirium, o cómo los conocemos o cómo se va a presentar en nuestros pacientes. Y es por eso importante estar atentos al cuadro clínico que va a presentar estos pacientes como personal de enfermería. ¿Para qué? Para poder intervenir de manera inmediata, prevenir los riesgos que va a tener este paciente y sobre todo abordar de manera oportuna estos pacientes con delirium. Es importante comentar entonces, como bien lo comentaba el maestro Ranan, que tiene tres aspectos muy importantes: un inicio agudo, un curso fluctuante y una alta alteración en la atención, ¿ok? ¿Cuáles son esos tipos o cuáles son esos subtipos en cuestión a cómo se clasifica el delirium? Son tres. Hay pacientes que se van a presentar de manera hiperactiva, otros pacientes que se van a presentar de manera hipoactiva y otros que van a ser mixtos. Desafortunadamente, hay un mayor porcentaje de estos pacientes que se van a presentar o van a tener características de un delirium hipoactivo. ¿Qué significa eso? Un delirium hipoactivo, que desafortunadamente el paciente va a estar con letargo, va a estar con disminución en la interacción y sobre todo, pues son pacientes que van a tener como si estuvieran sedados en mucho tiempo. Cosa contraria que el estado hiperactivo, pues esos pacientes van a presentar agitación, van a presentar deterioro en su función cognitiva, por lo cual desafortunadamente van a estar con desorientación, confusión, agresiones, que eso es muy importante y es un foco de atención para el enfermero neurólogo. ¿Por qué? Porque estos es la primera fase del deterioro neurológico. Y hay otros que son mixtos, que es la suma de los dos aspectos que son muy importantes. En la mañana puede ser el paciente que está totalmente relajado y en la noche, desafortunadamente, esos pacientes empiezan con alto riesgo de agitación, de alucinaciones y de desorientación. Es por eso importante estar atento a eso. Y fíjense nada más cómo es el impacto, la prevalencia que esto conlleva a que desafortunadamente la mayoría de los pacientes que tienen mayor datos clínicos como sedación o ventilación mecánica, aumenta todavía la tasa de impacto en cuestión a que presente un delirio. Next slide, please. Otro aspecto muy importante es el impacto y la relevancia clínica. ¿Qué me conlleva esto? Desafortunadamente, un paciente que presenta delirium me va a aumentar la tasa de mortalidad. Esa tasa de mortalidad a los 6 meses con delirium aumenta hasta en un 34-44% de acuerdo a la literatura consultada. Otro aspecto muy importante es el cómo es la mayor, que me va a impactar desafortunadamente a una mayor estancia hospitalaria. El promedio son 10 días adicionales a los días de hospitalización. Va a haber un aumento en la ventilación mecánica, por lo cual esta puede ser prolongada. Es un predictor independiente de mayor duración del soporte. Algo irrelevante que es muy importante en Delirium y de ahí tenemos que estar al pendiente de ellos es que va a haber un deterioro cognitivo. Es el riesgo elevado de déficit cognitivo persistente tras el alta y sobre todo, como les había comentado, va a haber un incremento de la mortalidad. Es desafortunadamente un predictor independiente de mortalidad a corto y largo plazo. ¿Ok? Next, please.
So, Joseph, hang on a second. Um, there's a challenge with it translating into English. I am trying to, this is the first time we've done it. Let me look at the caption settings.
Ok,
Hold on. It's pinned to the
no
bottom.
problem.
My speaking language is English. I'm going to hit Spanish and see if it comes. Oh, so everyone, my mistake. All right, start speaking, Joseph.
Ok,
Say something in Spanish.
ok. ¿Cómo están? Bueno, primero que nada, muy buenas tardes tengan todos ustedes. No sé si ya se esté traduciendo de español a inglés.
No, it's still. Oh. All right, try again. Try again in
Ok,
Spanish.
ok. Hola, ¿cómo están? Buenas tardes. Saludos desde México.
No, it's not translating it. Um, has anybody used the translation form? It is now in Spanish. Before it was in English.
Ok, ok, entiendo.
All right, I have a problem, but that's okay. If some people are able to, let me switch it back. I apologize. This is a new feature we're trying. So I'm gonna pop it out as an overlay, and then I am going to put the screen back up. Share.
Kathleen,
Yeah.
we can continue with you and leave me for last.
Actually, it's coming.
Va.
It's
Ok,
coming through now.
ok.
Go ahead. Go ahead, Joseph. Do you need me
Ya,
to move the slide?
no, no se visualiza.
Can you see the slide?
Yes. Ah, como bien les comentaba, algo muy importante. Sí, no sé, algo muy importante son los métodos o las estrategias que tenemos para lo que es la identificación sobre la valoración del paciente con delirium. Uno de ellos, la estrategia es la famosa CANICU. Esa CANICU es una herramienta de cribado más validada y utilizada a nivel mundial para detectar delirium en entornos críticos. ¿Cuáles son los aspectos muy importantes? Es que hay un uso multidisciplinario. Está diseñado principalmente para ser aplicado por personal, pues no especialista, por ejemplo, enfermería, médicos, que esto nos puede ayudar bastante para ir interviniendo en esta situación. Otro, pues nos ayuda a hacer una evaluación rápida. Este es un protocolo estructurado que se completa en pocos minutos a pie de cama y también otro aspecto muy importante es el paciente no verbal. No
Sorry,
verbal,
they were seeing
ok,
presenter screen.
no problem.
Hold on, I've got a display screen change. Okay, why is this? Sorry. Let me change. On my, okay. Sorry, Joseph.
No problem.
Go ahead.
Kathleen, maximize the presentation screen, please.
It's not big.
No.
I don't, all right. I don't know what's causing it because it's showing. I'm going to stop sharing and share again.
The slides are displaying in the presenter mode.
I know, I don't know why. Let me go here. There. Are they in big now? Okay.
Yes. Muy bien. Entonces les comentaba, en cuestión a lo que es la escala Kamiku, son cuatro aspectos muy importantes. Un mayor uso multidisciplinario, existe lo que es el paciente no verbal eficaz en pacientes intubados o con ventilación mecánica y sobre todo esta escala me da una alta fiabilidad en cuestión al uso que tenemos que tener con ellos. Otro aspecto muy importante es la evaluación del nivel de sedación. Para eso tenemos que utilizar nosotros el uso de la escala RAS, el Richmond Agitation Sedation Scale. ¿Ok? ¿Por qué evaluar primero la sedación? Esto es fundamental para determinar si el paciente está lo suficientemente despierto para interactuar y responder las pruebas de tensión. Una puntuación de RAS de -4 o -5 es una sedación profunda o no despertable como tal y estamos hablando de un estado de coma, por lo cual no va a ser posible evaluar el delirium. Tenemos que detener como tal el protocolo y reevaluar más tarde. En cambio, una puntuación de RAS de -3 a +4, que se está hablando de una sedación moderada a combativo, el paciente como tal está apto para la evaluación y tenemos que proceder al paso número 2 de la escala Kamiku. Next, please. ¿Cuál es el paso número 2 de la escala Kamiku? Es hablar del estado mental. En el estado mental vamos a tener un inicio agudo o un curso fluctuante del estado de conciencia. ¿Cómo tenemos que evaluar? ¿Hay evidencia como tal de un cambio agudo en el estado mental respecto al basal? Sí, sí lo hay. Y para eso es importante mantener esta evaluación. ¿El comportamiento ha fluctuado en las últimas 24 horas? Eso es lo que tenemos que evaluar. Entonces, son dos interrogantes que nosotros tenemos que ir como tal evaluando constantemente. Verificar si hay un cambio agudo del estado mental respecto al basal y otro si este ha ido fluctuando en las primeras 24 horas. ¿Ok? Entonces, estos son criterios de positividad, el cambio agudo o el curso fluctuante que nos va a dar como tal un resultado a un criterio totalmente positivo. Next, please. Paso número 3, la evaluación de la inatención. En este paso número 3 evaluamos como tal la capacidad del paciente para mantener la atención mediante instrucciones simples o de identificación de secuencias. Para eso, la escala nos maneja un ejemplo de una prueba auditiva, la famosa ACA, que diga que nosotros tenemos que comentarle al paciente que diga 10 letras y esas 10 letras tiene incluida la famosa letra A. Al momento de que escuche la letra A, el paciente totalmente debe de apretar la mano cada vez que escucha la letra A. ¿Cuáles son esas siglas? Bueno, tenemos la letra SAVEAHART. Entonces, cada vez que el paciente, nosotros digamos SA, tiene que apretar la mano, ¿ok? Entonces, en ese momento, pues el paciente está como tal atento a las indicaciones. Si no lo hace, desafortunadamente ya cumple un criterio que nos va a llevar a ese criterio positivo. Otro aspecto muy importante es la prueba visual. Para eso se tiene que hacer el uso de tarjeta con figuras simples para pacientes con déficit auditivo. Entonces, ¿qué puntos tenemos que realizar o qué interpretación tenemos que tener? La dificultad para digerir la atención, la incapacidad para mantener el foco y la dificultad para desviar la atención adecuadamente. Next, please. Ahora bien, el paso número 4, ¿ok? Va ya enfocado en lo que es el nivel de conciencia alterado. ¿Cuándo es positivo? Se considera que es positivo cuando el paciente presenta cualquier alteración del nivel de conciencia, es decir, que no esté alerta o que no esté tranquilo, ¿ok? Para eso tenemos que evaluar los estados de agitación y los estados de depresión, ¿ok? Tenemos que estar atentos si hay una hipervigilancia, es decir, una alerta excesiva inapropiada, o si el paciente está totalmente agitado con movimientos frecuentes, luchas con el ventilador o algún otro dispositivo invasivo que pudiese tener el paciente. En cuestión a lo que es el estado de depresión, tenemos que verificar si tiene somnolencia. ¿Cómo se verifica eso? Pues si se despierta con la voz o mantiene un contacto visual breve. Es decir, que al momento de que yo hago un estímulo verbal, inmediatamente el paciente apertura los ojos y ya no puede como tal estar nuevamente alerta hasta que se retira ese estímulo, vuelve a caer en somnolencia. Y estupor es una respuesta solo a estímulos físicos dolorosos y ahí nos da una semejanza, una puntuación de RAS de U-1 a -3, ¿ok? Algo importante, si el RAS es cero, se debe de proceder a evaluar el pensamiento desorganizado, que en este caso está en el punto número 4. ¿Y cómo es el punto número 4 de acuerdo al pensamiento desorganizado? Next, please. El pensamiento desorganizado va totalmente a evaluar las dimensiones de lo que es la evaluación y ahí tenemos que evaluar toda la función cognitiva de mi paciente. Si está alerta, orientado en tiempo y espacio, cómo está el habla, cómo está el lenguaje. Tenemos que verificar si existe incoherencia, si hay respuestas irrelevantes, si hay alteraciones perceptuales, ¿ok? En cuestión a la incoherencia, como bien les comentaba ya el maestro Renan, si hay pensamiento ilógico, inconexo o flujo de ideas fragmentado. Si hay respuestas irrelevantes, el paciente responde de forma inapropiada a preguntas simples o comandos. Y en cuestión de las alteraciones perceptuales, que son visuales, pues van a tener como tal estas alteraciones, ¿ok? Entonces, ¿cómo se evalúa? Aquí tenemos un ejemplo, un website assessment, donde se flota una piedra en el agua, se hace una pregunta que le hagamos cómo se flota una piedra en el agua, si hay peces en el cielo, ¿ok? Es algo incoherente, entonces tenemos que estar checando en ese punto. Y otro aspecto bien importante, si pesa más 1 kilo de plomo o 1 kilo de plumas, ¿ok? Ahora bien, next please. Vamos a ver como tal el algoritmo diagnóstico de Kamiko. Para eso tenemos que evaluar los 4 puntos, como bien les comentaba. El primer punto, si hay un inicio agudo, si hay un cambio en el estado mental o curso fluctuante en las primeras 24 horas, si existe una inatención, dificultad para mantener o dirigir la atención, ¿ok? Y si hay conciencia como tal alterada o el pensamiento que está totalmente desorganizado. ¿Cómo se diagnostica de acuerdo al CAMI-Q el delirium? Pues bueno, se confirma si se cumplen 1 más 2 o 3 o 4, ¿ok? Si esto se cumple, compañeros, tenemos un CAMI-Q positivo, ¿ok? Entonces, eso es muy importante tenerlo en cuenta. Next, please. Ahora bien, en cuestión a lo que es CAM y Q, ¿cuáles son las ventajas o las limitaciones? Para eso tenemos que hacer un balance en clinical application, ¿no? Entonces tenemos que tener las fortalezas o las debilidades. Y las fortalezas de esta escala es de que tiene una alta especificidad. Es eficaz para descartar delirium en pacientes sanos. Hay una rapidez de uso, es decir, la aplicación puede ser en pocos minutos integrada en la rutina. Hay una validación en pacientes con ventilación mecánica que está diseñado para pacientes no verbales o intubados y es muy accesible, ¿ok? Es aplicable por personal no entrenado, lo puede hacer como tal. Es decir, hablamos de no entrenado, una enfermera general, un auxiliar de enfermería. Cabe mencionar que las especialistas en enfermería, en cuidados intensivos, las neurológicas, pues son apropiadas a manejar este tipo de escalas. Ahora, las debilidades, pues tenemos una evaluación puntual, ¿ok? Puede omitir fluctuaciones si no es regular. El delirio hipoactivo, pues desafortunadamente hay una menor sensibilidad para detectar formas letárgicas y también una dependencia de RAS requiere nivel de despertar mínimo de RAS de +4, ¿ok? De -4, perdón. Y en cuestión al entrenamiento, pues tenemos que se requiere una formación específica para evitar como tal falsos negativos. Tenemos que estar evaluando constantemente para que nos estemos entrenando y tengamos mayor habilidad para exponer o para presentar o realizar este tipo de escalas. Otra escala que nosotros conocemos, next please, es la herramienta ACDSC, ¿ok? Entonces, ¿qué es la Intensive Care Delirium Screening Checklist? qué es este escala como tal? Es una herramienta de cribado diseñada para ser aplicable por el personal de enfermería, integrándose en la rutina de nuestros cuidados críticos, ¿ok? Es una observación como tal dinámica y esto se basa en el estudio mental, mini mental, el DSM-4, en el cual consta de 8 ítems, ¿ok? Que evalúa como tal síntomas nucleares. ¿Cuáles son esos? Pues bueno, le vamos a dar un punto si hay una manifestación obvia y 0 puntos si no existe como tal una manifestación. Y para eso, pues tenemos que mantener esa observación, a diferencia del CAMICU, ¿ok? Aproximadamente de 8 a 12 horas. Next, please. Ahora, ¿cuáles son esos periodos de observación? Pues bueno, tenemos que estar evaluando los siguientes puntos: el nivel de conciencia, la falta de atención, la desorientación, las alucinaciones, el retraso psicomotor, el lenguaje o el estado emocional, el sueño vigilia y sobre todo la fluctuación, ¿ok? Para eso tenemos que estar al pendiente, si es el nivel de conciencia, si hay alteración de acuerdo a la escala de sedación, ¿ok? Si hay inatención, dificultad para seguir algunas órdenes sencillas, si hay desorientación, tiene que estar desorientado en tiempo y espacio, ¿ok? Si hay alucinaciones, pues tenemos que ver cómo son ese tipo de alucinaciones, ¿ok? O psicosis que lo está manifestando. Y otro, el retardo psicomotriz, ¿ok? Entonces, eso es muy importante. Recuerden, la interpretación es de más o igual a 4 puntos. Ya es un diagnóstico altamente sugestivo de delirio. Siguiente, por favor, next. Ahora bien, de acuerdo a esto, compañeros, tenemos que evaluar qué es mejor, CAMICU o ICD-SC, ¿ok? Para eso tenemos que evaluar la metodología, el tiempo, las fortalezas, el requisito previo y el objetivo. En cuestión a CAMICU, pues la metodología como tal, pues es una evaluación puntual y es un algoritmo como tal de 4 pasos. En cambio, la ICD-C, pues es una observación continua durante el turno de 8 a 12 horas y se tiene que hacer un checklist de 8 ítems, ¿ok? Entonces, eso es algo muy tedioso. Una es rápida y la otra tenemos que hacer una observación en el tiempo que ya está estipulado. Otro aspecto muy importante, pues es lo que les comentaba en cuestión a que la escala CAMICU tiene una alta especificidad, principalmente para descartar delirium en pacientes con sedación o que ya están en proceso de destete de sedación o en ventilación mecánica. En cambio, la ICD-10 pues tiene una mayor sensibilidad para captar la naturaleza fluctuante y el delirium como tal hipoactivo. Si ustedes me dicen cuáles son las mejores, pues las dos son muy buenas y tenemos que ocupar las dos para descartar como tal cualquiera de las dos, cualquier dato de delirium que pueda presentar el paciente. Entonces, cabe mencionar que si ustedes utilizan Camico en sus unidades hospitalarias es muy bueno, pero si lo confirman con ICD-CS es también muy padre, ¿ok? Siguiente de favor. Next, please. Ahora, ¿cómo vas a elegir entonces la herramienta ideal en este aspecto? Next slide, please. Ahora, ¿qué es preferible? ¿Tener Kamiku o preferir ICDC, no? Para eso, pues tenemos que checar cómo son las fortalezas, cuáles son las debilidades, que es lo que acabamos de ver. La mejor herramienta es la que el personal domina, eso siempre, ¿ok? Toda escala que tú manejes es la que tú tienes que utilizar, ¿ok? Porque es la que tienes mayor habilidad, mayor destreza para poder diagnosticar o complementar tu valoración. Entonces, la mejor herramienta es la que el personal domina y aplica sistemáticamente, ¿ok? Se recomienda elegir una y estandarizarla en toda tu unidad hospitalaria. Sí, next, please. Ahora bien, como conclusiones, pues es importante pues estar monitorizando lo que es el delirio. Para eso tenemos que hacer de manera importante la utilización de estas escalas, ¿ok? Eso es importantísimo, la utilización de estas escalas para que nos ayude como tal a ir complementando nuestra valoración y abordar mejor a este tipo de pacientes con alto riesgo de delirio. Una detección precoz, ¿ok? Me permite identificar el delirio incluso en sus formas hipoactivas evidentes. Otro aspecto muy importante, la estandarización. Las herramientas como Kamiku y ICD-10 unifican como tal el lenguaje clínico entre personal médico y personal de enfermería. Los resultados clínicos como tal reduce significativamente la estancia en la UCI, la duración de la ventilación mecánica y sobre todo la mortalidad, que es muy impactante que un paciente tenga delirium porque aumenta mucho la tasa de mortalidad y sobre todo la seguridad a largo plazo que previene el deterioro cognitivo persistente y mejora la calidad de vida tras el alta hospitalaria. Un mensaje que se les otorga a todos ustedes para la práctica diaria es que la monitorización del delirium no es opcional como tal, ya debe formar parte de nuestros cuidados intensivos. Como tal, este es un estándar de cuidado esencial para la seguridad del paciente en estado crítico. Pues con esto concluyo. La verdad, aquí hay unas referencias bibliográficas donde pueden consultar más información sobre lo que es el delirium. Recuerden sustentar nuestra evidencia, nuestros cuidados con mayor práctica evidenciada y sobre todo también nosotros estar atentos a los escritos, a las actualizaciones que existen sobre estos temas. La verdad, les agradezco bastante su atención y estoy aperturado a todas las preguntas. Thank you for your attention. I open to any question. Sorry for speaking Spanish.
Thank you very much, Joseph, for that comprehensive presentation. I also see Renan has answered some of the questions in the chat box and have also provided us with some links and some references to articles. And others are saying, thank you, Joseph. It was a very good presentation. So I don't see any specific questions now, but I think they will also post it as we are presenting. So I think our last presentation for the evening will be from our president, Kathleen Woolman. So we are very honored to have you as part of our team, Kathleen. And I think there's not one country I think she hasn't presented in, and we are really always honored to have you as part of our team. And she's going to take us through the role of the nurse in preventing delirium. And I think, as I said, these three presentations really complement each other, how to assess what are the different tools, and then also now looking at some of the preventative strategies that we can implement in clinical practice to see how we can prevent that. So Kathleen, thank you so much. Besides the fact that she's the president of the World Federation, she's really also a very well-versed presenter, and she's really a clinical specialist in her area. So we hand over to you, Kathleen. Thank you so much. And we just keep on posting your questions, and we will attend to them as we go on. So thank you very much, Kathleen. Over to you.
Thanks. So basically, my focus is going to be on the prevention component, what we can do at the bedside in our standardized care of an ICU patient, not just mechanically ventilated, but an ICU patient, in preventing delirium from happening. So these are disclosures I have, but I am not sponsored to speak for this presentation. My only objective with you in the remaining time we have is to show you the evidence base around doing these bundles of care to contribute to preventing delirium. Because delirium, literally, the first focus is on prevention. That needs to be our role. That occurs by how we manage pain and do light sedation, that we control that first, that we consider using intermittent before continuous medication, that we use a standardized assessment scale, very much like delirium, but we use it for agitation as well, that we evaluate daily if a patient is on a breathing machine and sedation, a spontaneous wakening trial, a spontaneous breathing trial, and then the concept of implementing non-pharmacological strategies, which include mobility and paying attention to sleep. So this is what is called the ICU Liberation Bundle. And I also included promote sleep, because you will find that in the PADIS guidelines that they include immobility and sleep as risk factors in this whole component. Why are we putting this all together in a bundle, in a package? Because when you put it in a bundle, you have 72 2% less next day, the patient's going to be ventilated, 68% lower hospital deaths within 7 days, 65% fewer coma, less days in restraints. And I saw restraint concept question in there, as well as sleep questions, fewer readmissions to the ICU, 40% less days in delirium, and these patients tend to go home versus being transferred to an extended care facility. So putting it together, and the data really shows the greater compliance you have in all components of the bundle, the better those scores are. So assess and manage and prevent pain. The guidelines talk about using a numeric pain scale or observational CPOT, critical care observational tool, or behavioral pain scale. It's important we know pain negatively affects our ICU patients, that vital signs may be a flag that there's a problem, but it shouldn't be what we rely on to assess pain. And there is a recommendation that we should be protocolizing our assessment and management, and always treat pain first before you add dexamethasone or propofol as a part of that. And acute pain, we really should be looking at IV push fentanyl and not automatically putting somebody on a drip. If it persists or reoccurs, then we may want to consider a bolus and then adding a drip if needed. If patients have chronic opioid use, you may consider other, besides IV opioids. Some may use ketamine as a part of that. And then it's imperative that we work at transitioning the patient out of the intensive care unit with appropriate pain medication. And yes, acetaminophen, something we can consider using. And also, if the patient is experiencing neuropathic pain besides opioid, we may use some of the meds that are gabapentin that are specifically focused for neuropathic pain. On agitation, the C, choice of sedation, I sort of put those together. We want to assess this every 4 hours using a standardized scale. The one that probably has most reliability and validity on it is the RAS tool, where our target is 0 to -1 to +1. So a very narrow window there. And the SAS is another tool, and its scoring target is 3 to 4. So it does it slightly different. Which tools are, and feel free to put this in the chat box, which tools are currently being used in your ICU to assess agitation? I'd love to see around the world. RAS only. RAS, okay. RAS. It's a much more objective tool, in my opinion. Elaine is using SAS, so both are considered acceptable in the guidelines, but all the guidelines focus on targeting lighter sedation, using sedative medications to maintain lighter levels of sedation unless contraindicated, unless you're having a different target, and using daily wakening and nurse protocolization to target that sedation to make it lighter. Talking about using drugs that are not benzodiazepines. Oftentimes that was our first choice, and it literally has data that shows it contributes to the development of delirium. And in the updated guidelines, there's insufficient evidence to make a recommendation to use benzodiazepines to treat anxiety. I'm not talking about agitation. I'm talking about anxiety in patients admitted to the ICU. The suggestion is the use of dexamethasone over propofol if it is available for sedation in mechanically ventilated patients, when your highest priority is to achieve light sedation and delirium reduction. That's coming out of those 2025 guidelines. And in cardiac surgery patients, there still is a recommendation of using propofol over benzodiazepine. And it looks like UCLA, some of the places in Southern California are using the RAS. So the other component, the next component of this is wake up and breathe. If your patient is on a mechanical ventilator, and if they're on sedation and not on a mechanical ventilator, you still may want to do the wake up, but specifically on mechanical ventilator. This research was done in the 2000s, and it has taken us this long to structure within our clinical environment. So I'd like to ask you guys that are on here, how many of your ICUs are routinely doing a spontaneous awakening trial? In other words, evaluating for safety and doing the trial if it is safe to do on a daily basis with your mechanically ventilated patients. Unless contraindicated. Amanda, SAT and SBT unless contraindicated. Daily, Q-day, great, because it makes a difference on ICU length of stay, fewer diagnostic tests, less challenges with PTSD, no changes with that. There is a very specific criteria for a safety screen. What are you looking for? If the patient passes the screen, then, and it basically checks for contraindications, then these are absolute contraindications that we don't, if they're receiving a neuromuscular blockade, if they've had an MI in the last 24 hours, we don't want to do this. But if they do the screen and they pass the screen, then both sedative and pain medication is stopped. If the patient is able to open their eyes, look at the caregiver, squeeze their hand, and put out their tongue, then they've passed the SAT. We don't need to restart that medication. If they fail the SAT through agitation or they're unable to do these components, then we take a look at what are our next steps. It can be started, if it's agitation, it can be started 1/2 of the prior dose and then increased as a part of it. So when they put these two things together, the SAT and the SBT, they did it to show the power of combining the two on ventilator-free days, ICU, hospital length of stay, survival, coma, and delirium. So I saw on there, we're doing SAT, SBT. Carly mentioned that on a daily basis. They're putting them together. When these are put together, you can see 3 days off the vent sooner, 2 days faster to extubation, 5 days faster to ICU discharge, carried that out to the hospital. An improvement in mortality was seen and an improvement in coma. So putting these together, even 90 days out or a year out, you can see a difference in mortality. That's how important this is. And I know outside the United States and Canada, nurses run the ventilator. So you really have control over both of these. In the United States and Canada, where we have respiratory therapists, it has to be coordinated. So this is a number needed to treat of 7 patients in order to have these outcomes and save a life. That's pretty powerful. So SBT has a safety screen as well. And these are the criteria. If they pass the SBT, they're screening if they are able to achieve these. And then there is a discussion about extubation. Now, which is better? How many are doing a 2-hour breathing trial or a 30-minute breathing trial for their SBT? I'd be curious to see. This was RCT of about 1,200 patients, 18 ICUs in Spain. Evan said 30 minutes. That's really where the data is going. This was mostly MICUs, median 4-day on the vent. There was your inclusion criteria. They were randomized to 30 minutes or 90 minutes, and you can see there was a difference in mortality. Less patients got trached, less reintubations, and they were successfully extubated at 82%. So we don't have to hold them breathing through a straw for 2 hours anymore. What do we do for delirium management itself? So we're screening, and in rounds or with our physician colleagues, we say the patient is delirium positive. What are the next steps? oftentimes you'll find in rounds, it just sort of gets glossed over. They should be taking a step and doing what is called stop, think, and medicate. Stop. This directs the clinician to assess any prior interventions that may be contributing to delirium. Think, toxic. Are they hypoxic? Are they taking meds that are toxic to the brain? Do they have an infection or sepsis, or are they immobile? Are we doing the right non-pharmacological interventions, and are there electrolytes in line? And so the non-pharmacological strategies, because this is something we have the capability of partaking in, sleep promotion. Don't wake them up at 3:30 in the morning to do a bath. Get them up in the chair. Light up the day, dim at night. Limit the evening use of a television. Find out what their strategies are. In the daytime, if they have hearing aids, things like that, control the noise. Mobility is the only evidence-based intervention that has been shown and proven to reduce delirium. So make sure we've got protocols and algorithms that allow for appropriate mobility and safe, and the science shows that we can do it. Other things, you can do cognitive stimulation with music and things like that, and sedation interruption, like we talked about, the SAT, and sleep promotion as a part of it. Early progressive mobility. How many of your organizations are doing ECMO? Extracorporeal membrane oxygenation. They are ambulating these patients with all of those tubes in place. So CRRT, all of it. Patients, we need to push them to get them out of bed and use some type of algorithm, protocolized process where we're partnering with our physical therapy, not just giving it to physical therapy to do. And what do the guidelines say? Suggest providing enhanced mobilization rehab over usual care. On average, it should start within 24 to 48 hours. Enhanced mobilization is defined as cycling, stepping, early mobility protocol, up 2 times daily, and it's protocolized. And it is multifaceted, and it does take a team to do. So how many have a mobility protocol in their intensive care unit? So Paolo, I'm curious, are you ambulating your ECMO patients? We have initiatives, Michelle, that's good. You have mobility stages, Amanda, stage 1 through 6. Mobilization, verticalization is another. There are some beds that will verticalize. The other piece of the ABC, the last one is F, and that is family. Engaging the family and the patient in the ownership of their care. And there are many resources to successfully do this. But what are the core concepts? Dignity and respect, sharing information with everyone, getting them to participate in those care decisions so that they own their care and collaborate with the whole team. So Paula said, not a specific protocol, but we are introducing some steps. So there are wonderful protocols out there, Society of Critical Care Medicine, AACN, and Paula, if you're interested, I have one too that I worked on a national initiative. But when we talk about family and patient and the caring component, this is one of my favorite quotes. I have learned that people will forget what you said, they'll forget what you did, but people will never forget how you made them feel. They need to feel like they belong in this process. Sleep is critical. The consequences, and you all know when you don't sleep, what are the consequences? But there are cognitive and neural consequences for different components of your sleep. Memory, your REM sleep is impacted by it. You become more susceptible to delirium. And so being able to ensure sleep is a part of that journey. And that's why I included it, even though it's not on the official bundle. But if you guys take a look at what are the ICU care activities that impact sleep, noise, light, and our interruptions. These are all things we have the capability to be able to manipulate. And there is data on sleep protocols before and after showing a reduction in delirium. What do sleep protocols mean? That basically means you're organizing the interventions that take place at night so that you're having as much uninterrupted sleep time for the patient. So you don't have x-ray come in at 4 in the morning, lab come in at 1. How many experience that in their environment? You don't bathe in the middle of the night as a part of that. And so the PADIS guidelines, they do suggest promoting multi-component protocols to manage sleep in the critically ill. So having a sleep protocol does make a difference. I created a sleep protocol when I was practicing nights in the 80s and then shared it with my staff in the 90s as a result of it. What's included? Sleep assessment, optimizing control for light and noise, cluster those activities, decrease the stimulus at night. You can use earplugs and masks, music, passive vital sign monitoring if you can, and then increase their activity during the day so they're naturally more tired to be able to sleep at night. And you want to individualize this because sometimes there are patients that bathe in the evening to help them sleep. So a 10 o'clock bath may be appropriate for that patient. Or they may fall asleep with the TV on. So we leave the TV on for them. Or they fall asleep listening to music. So some things to think about and exciting things that we can do. So promoting the uptake and compliance of this bundle, set daily patient goals. And that includes sleep, mobility. They should have the daily goals of their medications and the SAT and SBT. If you have bed rest orders, get rid of them and say activity by protocol and build a protocol so that the default is not bed rest. Man was not meant to hang out in bed. On all of these, you need to monitor the individual bundle compliance. Get that bundle compliance up, then start looking at your outcomes and share that with the group. And report on a regular basis at the unit level so that staff know that what they're doing is making a difference. Or we can identify as a collective group what is getting in the way of your ability to do this. So I'm going to leave you with this. When would now be a good time to do this? It's not enough for us to do our best. We have to know what to do and then be able to do our best. So thank you very much, everybody. This is the link, but it is also the QR code for your evaluation and then having a certificate of attendance sent to you. I see Gasa said, I know, just wow, fantastic idea. It's, you know, it's often simple things, and we're in a very high-tech environment, engaged in the drips and the machines, and we have to remember that person in the bed and all of those things that we know help move them towards healing should not stop just because they have lines